Welcome to Roadmap to Residency Evidence-Based Application. In this video, we will be discussing about fungal infections. So I'm Aviraj and welcome to our Club 250 Matchmaker sessions. So how do you diagnose a fungal infection? So diagnosis begins with microscopic methods and specialized strains. Diagnosis then continues with the following, like culture, which may take several weeks in case of fungi. Especially fungal infections include inhibitory mold agar as modification of several with antibiotics. So several agar and blood agar, both with antibiotics, can be used. Culture identifies fungal morphology and PCR with nucleic acid probes. Serology includes antibody screening and complement fixation and looks for patient antibody. Fungal antigen detection in patient CSF or serum. For example, cryptococcal capsular polysaccharide detection by lattice particle agglutination or counter immunoelectrophoresis. Skin test is most useful for epidemiology or demonstration of allergy to an agent patient is infected with. Otherwise, like tuberculosis, a skin test only indicates exposure to the agent. Now, these are the different microscopic methods and special fungal stains that can be used. So first one is the KOH wet mount, where the fungal color is colorless and can show fungal elements. Iodic acid surface stain can show the fungus as a hot pink. Silver stain, gray to black in case of Pneumocystis. Calcufluor white, which can stain bright blue-white on black. And India ink wet mount of CSF sediment, which can stain colorless cells with halos. Non-systemic fungal infection, superficial infection of the keratinized tissue. The first of we have is Malassezia furfur, which is a normal skin flora, and diseases include pityriasis or tinea versicolor. It is a superficial infection of keratinized cells, uh, occurs in moist, warm climate, and causes hypopigmented spots on chest and back. KOS mount of skin scales shows spaghetti and meatballs. Yeast clusters are short and curved-septed hyphae. Coppery orange fluorescence under wood lamp. And treatment is topical selenium sulfide or topical azole antifungal. But fungemia can happen in premature infants or intravenous lipid supplements. Cutaneous fungal infections without systemic disease. So first of all, we have the yeast skin infections, which is commonly cutaneous or mucocutaneous candidiasis, may disseminate in compromised patients and discussed with opportunistic fungi in the later slides. So the first one we have dermatophytes, which are a group of fungi. It is a filamentous fungi, monomorphic, and only infects the skin and hair and or nails and do not disseminate. There are generally three genera of dermatophytes: Trichophyton, Microsporum, or Epidermophyton. Trichophyton infects the skin, hair, and nails, and Microsporum infects the hair and skin. Epidermophyton, whereas, infects nails and skin. Please remember these points. Diseases include dermatophytic infections. Tinea capitis is a ringworm of the scalp, which is very contagious and causes permanent hair loss. Tinea barbae is a ringworm of the beard age region. Tinea corporis, which is a dermatophytic infection of the glabrous skin. Tinea cruris, which is also called as jock itch. Tinea pedis, so called athlete's foot. And Tinea unguent, which is the ringworm of the nails. If symptoms include high inflammation, it is generally from animals. So if symptoms include little inflammation, then it is generally from humans, transmission, right? So diagnosis is made with microspore, fluorescence of bright yellow green, and KOH amount of nail or skin scrapings. Treatment is topical imidazole or tolnaftate, and it keeps the areas dry. So subcutaneous mycosis, Sporothrix zenki, is the first organism that we are going to talk about. So it is a dimorphic fungus and it has environmental form that's on plant material and worldwide as hyphae with rosettes and sleeves of Candida of Conidia. There can be traumatic implantation in case of rose or plum tree thorns. This is a very important organism and very frequently asked in the examination. That is sporotrichosis. So sporotrichosis, also called as a rose gardener disease, is subcutaneous or lymphocutaneous lesions. Treatment is itraconazole or potassium iodide in milk. Pulmonary sporotrichosis is in urban alcoholics, particularly homeless persons. And treatment is itraconazole for bone or joint infection and amphotericin B for severe systemic infection. So there are four important classical pathogens in the United States. All of them cause acute pulmonary, chronic pulmonary, or disseminated infection. Histoplasma, Coccidioides, Blastomyces, and Paracoccidioides. So first of all, will talk about Histoplasma capsulatum, which is a dimorphic fungus. It has environmental form hyphae with macroconidia and tuberculate macroconidia. In endemic region are Eastern Great Lakes, Ohio, Mississippi, and Missouri river beds. Now, in case of these systemic infections, these endemic regions are very important and sometimes maybe the only clue for you to diagnose the disease in the examination. So please have a hold of where and which areas these organisms are predominant, like in which areas histoplasma is predominant, that is in Ohio and Mississippi and Missouri river beds. It's found in soil or dust enriched with blood or bat feces. Spelunking or cave exploring, cleaning chicken coops, or bulldozing starling roots may be the cause or risk factor. Tissue form are generally small intracellular yeast with narrow neck on bud, and there is no capsule. They are the facultative intracellular parasite found in reticuloendothelial cells. This is the histoplasma environmental form, and this is the histoplasma reticuloendothelial cell form. Now, diseases include fungus flu, which is a pneumonia. It is asymptomatic or acute but self-resolving pneumonia with full acute symptomatology. Hepatosplenomegaly may be present even in acute pulmonary infections. Very common in summer in endemic areas, children or newcomers. Lesions tend to calcify as they heal, and there is relapse potential with T cell immunosuppression. Disseminated infection, mucocutaneous lesions are common, also common in AIDS patients in endemic area. Treatment is itraconazole for mild disease and amphotericin B for severe disease. Now let's talk about Coccidioides immitis, which is also a dimorphic fungus. We can see this is a picture of Coccidioides immitis, and this is a histological picture of spherules of the Coccidioides immitis. Now, it has environmental form which consists of hyphae breaking up into anthroconidia found in the desert sand. The endemic region, again, which is very important, is Southern California, Arizona, New Mexico, Texas. Now, these anthroconidia are inhaled, round up, and enlarged, becoming spherules inside, which is the cytoplasm walls off and forming endospores. Now, then the tissue form is there, which is spherules with endospores. Disease, it causes valley fever, which is asymptomatic self-resolving pneumonia. If there are desert bombs, erythema nodosum and arthritis, then these are the good prognostic sign. It is very common in endemic region, and the pulmonary lesions tend to calcify as they heal. Systemic infection is a problem in AIDS and immunocompromised patients with endemic regions. Treatment is azole, that is itraconazole, and amphotericin B for severe disease. Blastomyces dermatitis, which is also a dimorphic fungus. Environmental form consists of hyphae with node script conidia. No definitive association, although may be associated with rotting wood such as beaver dams. Endemic regions are Ohio, Mississippi, and northern Minnesota. Tissue form are broad-based budding yeast and a double retractile cell wall, which is not a capsule. Here we have hyphae with conidia and broad-based budding yeast of Blastomyces. Now let's talk about some of the opportunistic fungi. And the most common of that is Aspergillus fumigatus. It is also a monomorphic filamentous fungus, dichotomously branching and generally have acute angles, which is a very important factor. Frequent septate hyphae with 45 degrees, and one of our major recyclers are composite pits and moldy marijuana consist of this. So Aspergillus sui, monomorphic filamentous fungus, and Aspergillus fumigatus. Here we have the pictures of both. Here we can see the acute angle branching, and this picture is almost always present in the examination, which will help you identify the case. So disease predisposing conditions include the following: allergic bronchopulmonary aspergillosis, asthma, cystic fibrosis, fungus spore, preformed lung cavities can be there. Invasive aspergillosis may be presentation. It invades the tissue causing infarcts and hemorrhage, and there is nasal colonization leading to pneumonia or meningitis. Psoriasis in born patients may also disseminate. Treatment is voriconazole. Now let's talk about Candida albicans. So it is a yeast endogenous to our mucous membrane, to our mucous normal flora. Candida albicans yeasts form germ tubes at 37 degrees Celsius in serum. It forms pseudohyphae and true hyphae where it invades the tissues. Candida diseases or predisposing condition. Polyp, which causes cervices of mouth or malnutrition, oral thrush or prematurity, antibiotic use, and immunocompromised growth in AIDS. Esophagitis, gastritis, septicemia, endocarditis, cutaneous infections, yeast vaginitis can be there. Diagnosis is made with KOS mount, and treatment is topical oral, imidazole, or nystatin, and hepatitis B. Now, which of the following fungi endemic to Ohio is found in soil enriched with board fishes? As we all know, Histoplasma capsulatum. Silver stain is used to identify which of the following fungi? Pneumocystis. Thank you for watching.